Hi, everyone. So I think we're going to go ahead and get started now that the trickle of people has slowed down. So welcome everyone to the 2023 Radiology Bootcamp. We're all very happy to see you guys here, and just want to go ahead and start off by thanking the residents who are graciously dedicating their time. Some quick notes before we start. There's going to be time for Q&A at the end. So if you have a question during the presentations, just put it in the chat. Start with your name, your year, and where you're from just so they can easily see that it's a question, not something else. There's going to also be a survey link that's sent out. A copy of the slides will only be sent out to people who fill out the survey. It's for feedback, to let us know how we can improve. And lastly, the recording will be sent out to paying APAMSA members. So if you want access to that, please just go ahead and join APAMSA. Without further ado, I think I'll hand it over to our residents.
Hey everyone, I'm Ying. I am a PGY3 at APAMSA. So we'll just be getting started. The 3 sections. Let me just share my screen here. All right, you guys are able to see my screen. So there's going to be 3 parts to this radiology primer that we'll be giving for you guys. In my section, I'll be talking about etiquette, pre-meds, and a systematic approach to chest X-ray interpretation. And then we'll take a short break, and then Jen will take over with abdominal X-ray, CT, abdomen, pelvis, and brain imaging 101. And then John will close off after a short break on like the radiology workflow and radiology on call, so you know sort of what to anticipate when you're communicating with radiology and what you need, imaging modalities, and how to ace your radiology rotation. So let's get started. All right, so the first things first with etiquette. Please, if you take away nothing from this talk, the one thing that I would love for you to take away is to please include a clinical indication. It is so absolutely important to us. It helps us protocol studies, look for specific pathology, look for specific complications, and provide an informed differential for you guys. And that just overall just helps best answer your question. If you're not sure what to include, that's okay. Just think about like, you don't just order imaging for the sake of ordering imaging. You probably have some type of differential, or you can explain, for example, a patient has like E. faecalis bacteremia, and that would be helpful to us, or if they have any surgical history, that's just sort of predispose our prior probability when we're interpreting each imaging. So help us help you. If you have no idea, sometimes that happens, that's okay. So this is an example of 2 real indications I've received. So clinic visit, that's not helpful. And then a better indication would be abdominal pain. It would be nice if you could also specify the quadrant, status post PTC exchange yesterday. And before a contrast enhanced study, I know you guys do this, but please, I think it would be helpful just to review to whether or not the study will change management, because you have to consider cost for patients. Is IV contrast necessary to answer the clinical question? It definitely makes the images look pretty, but is it truly necessary, especially if the patient has like decreased renal function? Do they have a history of contrast reaction? And was that to iodinated contrast, which is what we use for CTs, or for gadolinium-based contrast, which is what we use for MRI? And what exactly was their reaction? Was it like a little tickle in their throat, or did they have anaphylaxis? And overall, do the benefits outweigh the risks? You can discuss with the radiologist if you're not sure. And if there is this risk-benefit discussion, it's always important to also discuss it with their patient and document the discussion in the chart. In terms of pre-medication, when do you pre-medicate? So really the only time you need to pre-medicate is if the patient has had a prior moderate to severe reaction to iodinated contrast. If a patient has asthma or multiple allergies, they may have a very slight increased risk of developing a moderate to severe contrast reaction, but there's really no indication for pre-medication. And if patients have a shellfish or seafood allergy, hypersensitivity to betadine or other iodinated compounds, or any prior severe reaction to gadolinium-based contrast, which is used for MRI, you do not need to pre-medicate. So next, we're going to pre-medicate. What are the options that we have? These are 3 example pre-medication regimens. So we have the oral regimens, which I've shown in this box here, and that's the 12-hour prep and the 13-hour prep. The oral pre-medication regimen is preferred if it's like a low acuity section situation, because it's lower cost, it's more convenient, and most of the trials that were done in like patients who took oral pre-medication. So you typically use it in like outpatient or ED or inpatient settings. But we do have an IV pre-medication protocol that uses hydrocortisone, and that's just a 5-hour and 1 hour prior, plus Benadryl 1 hour prior. And that's what you do if a 12 or 13-hour prep will adversely delay care. If you have any questions about specific scenarios, missed doses, or just want to read more about the evidence, you can look up the ACR manual on contrast media. Just Google it. The PDF is available and free, so you can dig deeper into that. Great, so now we have gone through the basics of ordering your imaging after you've decided that it's appropriate and indicated. So let's start with an approach to chest x-rays. So we're going to start with the basics of image formation. Basically what happens when you're getting an x-ray is you have an x-ray source. It shoots out these little photons, particles of light, which will hit the individual or pass through the individual or get absorbed by different tissues, and it hits the image detector. So this is an example of a PA view. And the result is if the photons go all the way through with not much barrier, such as in the case of air, then it will show up on your chest x-ray as black. And whereas if it hits a very dense object such as bone, then it'll get absorbed by the bone, so it doesn't hit the detector, and you end up with something white. And soft tissue and fat are sort of in between, and there'll be shades of gray. And that's how you end up with your chest x-ray. So you see that lungs are black, bones are white, and everything else is sort of in between. And it's not totally black for the lungs because, I mean, it's also soft tissue. And then in terms of projections, you might have heard APPA. The name is just the direction of the X-ray beam. So a PA radiograph would go from X-ray beam from posterior to anterior. So the patient is standing and their chest is against an image detector. This is done in an outpatient setting or an ambulatory setting. And then anterior posterior, or AP, is what we get with portables. You might have it supine, as in this example where the patient's just laying on their back, or semi-erect where they're somewhat propped up. And you can see that there's a difference in how far the X-ray projection is from the image detector in PA versus AP. PA is much further, whereas AP, it's very hard to get that same distance, especially in patients that are hard to maneuver. So it's like, for example, 72 inches versus 40 inches. And the heart is further away from the image detector in the AP setting. So what that results in, if you've ever played with shadows, the closer you are to your flashlight, the more unrealistic and big that your shadows might show up, whereas the closer your hands are to the wall, the truer to the size it is. And that's the same case with what you see with the PA. So in the PA, the heart shadow is truer to the real size, whereas in AP, the heart is magnified. So this is an example of chest x-rays. You can of the same patient, and this was actually taken within a day of each other. There was no change in their respiratory status, and they don't have any underlying heart disease, but the top one was taken PA and the bottom one was taken AP. So what's different? The bottom heart looks bigger, but really it's the same. They're the same picture and the same heart. So next we can go over basic anatomy. So anatomy is the foundation for all of radiology. If you know anatomy, you can sort of figure out like what is wrong in localized pathology. So I've labeled this chest x-ray for you. So you can see over here that we have the superior vena cava draining to the right atrium. The right ventricle does not form any heart borders on an AP view. And this is the pulmonary outflow tract. You have the aorta here, the left atrial appendage, sometimes you can see here, and the left ventricle is down here. And then on the lateral view, you'll see that the right ventricle forms the anterior border of the heart, left ventricle and the left atrium form the back, and you can see the aorta here. And the right atrium is not border forming on this lateral view. And this is just some cross sections from CT, just so you can believe me, this is what it looks like. Things that you make note of is the size of the heart should be approximately less than half the width of the thorax. This is just something that you eyeball. You don't need to measure this. And if it's enlarged, then you'd be concerned for cardiomegaly. And then these are relevant structures that are labeled. So over here we have the trachea, and then the aortic knob, the azygos vein, which drains into the SVC. We have the clavicle, scapula, right hemidiaphragm, left hemidiaphragm. This is what we call the costophrenic angles. These are the cardiophrenic angles. And then you can see a little stomach bubble here. And then on the lateral view, I've labeled the sternum. Down here is the trachea, which goes down into the main stem bronchi. And then you can see the right upper lobe bronchus here and the left upper lobe bronchus is all sort of in a line with the trachea. They're all in one straight line, and they'll be important later. This is right pulmonary and left pulmonary artery. Esophagus is behind the trachea. Your IVC, sometimes you can see it down here. You want sharp costophrenic angles. And then the vertebral bodies should be approximately the same height to each other. You want to make sure you're not missing like a compression fracture. And then we have the left hilum and the right hilum, which are essentially just the pulmonary arteries is what it's referring to. Most of the time in 97% of patients, the left hilum is slightly higher than the right hilum. So if the right hilum ends up being the same height or a bit higher, you might be concerned that something's either pulling or pushing it upwards. And sometimes people say it looks like little fingers. These are where the heart valves would be. So your aortic valve, pulmonic valve, mitral, tricuspid. We sort of split it in half. If you want to remember it, you can just think of it as PAMT. It's not a great mnemonic, but you just go zigzag and that's how you see it. And then similarly, if you see on the lateral, just draw a line through the middle and you can sort of go PAMT, same situation. You can see, you can tell like which valve is what based on like the angle of the valve replacements that you see. You obviously cannot see the valves on just this regular chest x-ray. It's only when it's replaced, as in this case of a patient who had every single valve replaced. And you can also tell which valve it could be if you're not sure based on its orientation. All right, next is fissures. So we have a major fissure, minor fissure, right upper lobe, right middle lobe, right lower lobe. And normally you're not going to see the fissures. That's why I drew it up for you guys. You only see it if it's filled with stuff. It could be filled with fluid or filled with cancer. All right, and then I want to talk about 3-ish clear spaces. So in addition to identifying structures that are there are also, it's important to know when there should not be something present. So the 3 spaces that we talk about, there's the retrosternal space, so it's behind the sternum, and then the retrocardiac space, which is behind the heart. So you might see this retrosternal space filled in if there's a mediastinal mass, or if the right ventricle, which is inferior to it, is enlarged. You may see the retrocardiac space filled in the setting of this left atrium or left ventricle being enlarged, or if you have a diaphragmatic hernia that's coming up, or if you have a consolidation there. And this other thing is not a space, but it's a concept called the spine sign. So as you go downwards with down the lungs, it should get darker because you just have more lung. But if you don't see that and it seems to get like whiter, then you'd be concerned that maybe there's like a paraspinal mass, or you have a consolidation there, or some pleural based mass. All right, so let's just quickly go through some examples. I just want you to, we don't really have time to go back and forth, but just think of the answer and your interpretation of the image when I present it. So what's abnormal here? So the heart looks big. And so you would say globular enlargement of the cardiomedial sinus silhouette. It doesn't look really like there's any pulmonary edema. There's no fluid, and the costophrenic angles are sharp. And this is a hint here with these arrows on this lateral view. You sort of have the epicardial fat as well as the retrosternal fat sort of forming like a little Oreo cookie sign. And there's some like radiopaque stuff in between. And another hint is this is a typical appearance of what we call a water bottle heart. So this patient has a pericardial effusion. So that's the fluid that you see is the white part of the Oreo cookie. And this is why the heart is so globular in appearance. And this is what their CT looks like. They had a uremic pericardial effusion, and they were treated with like hemodialysis and pericardiectomy. All right, what's abnormal here? So this heart is also enlarged, and once again, you don't see any evidence of pulmonary edema, but what you do see is the right heart border seems to be bulging out along this side, and so does the right hilum. There is a hint, this lateral is very helpful. I know we're used to always looking at frontals, but laterals can actually give you a lot of information. There's some arrows here that might help you as well. So we talked about spaces. So you see over here that this retrocardiac space is filled in. There's a lot more stuff there. So what is actually happening here is this left atrium is enlarged, and you can tell that this is a chronic process because there's calcification along the walls of the left atrium. And another hint that you have is that you have a mitral valve replacement here. And then what we see here is what we call the walking man sign. So remember how I said you have the trachea goes, and then you can sort of see the right upper lobe as one circle, and the left upper lobe circle should be, for the bronchus, should be right below it in a straight line, but it's sort of splayed apart like a man who is, or woman who's walking. That's what we call the walking man sign, which just tells us there's something here that is causing them to sort of get splayed apart. So this patient had left atrial enlargement from chronic severe mitral stenosis, and they had a mitral valve repair. And other things that we take note of, there are a lot of lines and stripes. There's like a whole 17-page paper on this, if that's something you're interested in, that of things to note. If it's abnormal, you'd be concerned that there's something there. So this right paratracheal stripe is basically when the pleura of the right upper lobe contacts the mediastinal fat and the right tracheal wall, and it goes down to this like right tracheobronchial junction. And that contrast is what you see here. And I've shown it on the CT as well. So it can be widened in the setting of lymphadenopathy, if you have a mediastinal or esophageal mass, aortic disease, or neurogenic tumors. So in this case, you see that this stripe is no longer super nice like what is labeled originally. There's something big there. And you can see that on the cross-section CT as well. This patient had a large ectopic parathyroid adenoma, which was in their mediastinum. So another stripe that we look at is something called the aortopulmonary stripe, and that's just the pleura of the left lung that's contacting the mediastinum of the left pulmonary artery and the aortic arch. There's supposed to be this nice straight line here, and you also see the correlate on the CT. And in this case, you can see it can be elevated in the setting of if you have masses, if you have lymphadenopathy, or in this case, you can see on the x-ray that there's air sort of dissecting that nice line there. And that's because this patient has pneumomediastinum, or air within their mediastinum. Okay, and then what's abnormal here? So earlier we talked about the heart being large, but the heart looks like it's probably okay, but something is wrong here. So this is widening of the mediastinum. We no longer have that nice right paratracheal stripe. In fact, the left paratracheal stripe is also widened. And the lateral helps this because the retrosternal space is filled in. So that makes you concerned that you have a mediastinal mass. And this patient indeed had an anterior mediastinal mass. It was a kid with lymphoma. And that is what it looks like, very ugly. Another example here, what is abnormal? This is a dialysis catheter. It's fine. It's kind of hard to see. So if we window it, then you'll see that it looks like there's sort of a regular gas in this area, but it didn't look like our case of pneumomediastinum, and that's not what you expect the lungs to look like. So what is another thing that you think it could be? So this patient actually has a diaphragmatic hernia. So you can see on this lateral sagittal CT that the stomach is like herniating upwards, and similar over here, there's just like stuff here, and that's not the heart. So lots of things to think about. What's important is that you just have a systematic approach to avoid missing things, because you can get satisfaction of search and be like, I'm done, but there might be more than one important finding. So internists and surgeons, like they all love this ABCDEFG situation. You're welcome to do that. And that's like airway, bones, cardiac diaphragms, effusions, fields, like your lung fields and the great vessels. If that's what works for you, you can do that. What I like to do that doesn't require memorizing these letters is just go in a way that makes sense. So just for a frontal, like I start with the thing that you're never going to forget to look at the lungs and the heart when you're looking at a chest x-ray. but you might forget to look at the bones, soft tissues, and the upper abdomen that's like partially imaged. So that's what I start with. So first look at the upper abdomen, and then afterwards, I just sort of scan the bones and the soft tissues going up the right, coming down the left, and then I go down like the central airways, and then once again, go up and down to looking at the mediastinum and the hilum, easy to miss stuff there, and then go up one lung field, down to the other lung field, and just sort of grossly bilateral lung fields. And you can have a similar approach with the laterals as well. Honestly, it doesn't matter what you do as long as you're consistent in your approach to make sure that you don't miss anything. One of you had asked if we could speak about windowing. So to do that, I need to mention that there is something called the Hounsfield scale, Hounsfield unit. So basically, as I said, with chest x-rays, different densities will have like different like whiteness or darkness based on its density. So air, for example, on a CT would be like -1000, and bone would be really bright, it'd be greater than 1000. So this isn't the case for CTs, and soft tissues would be in the middle, 30 to 45, and contrast is up here. So in terms of window width and window level, you can window your chest x-rays, but this example, I'm just going to talk about CTs because it's easier to conceptualize. So window width is just the range of grayscale that you have, and manipulating that adjusts the contrast. So we have a window width here of 600 Hounsfield units because it's centered around a window level of 0 Hounsfield units. That's the center of the range. So it would be +300 and -300. So if you have a really big range or a really big window width, then the differences between all these intermediate shades of gray will appear more similar. Whereas if you have a smaller range or smaller width, then the differences is greater, then you have more contrast. So this is just an example. You can see here width and with W, and level is in L. So you can see, for example, in a bone window, you have a big range, but you don't really care about all this other stuff. You're just looking for the difference between the bright bone and everything else. And then the level, we put it at 500 because remember, our cortical bone here is much higher. It's like in the greater than 1000. Trabecular bone is 300 to 800. So we center it at the thing that we want to look at. Whereas lung window, we showed here that air is -1000. So we're centering it at -600. We still have a big window width because we want to get that high resolution when we're evaluating the lungs. And then with the abdominal window, we center it at 40 because remember, soft tissue here is 30 to 45. And then our window, we make it much narrower because now we're focusing on all these different organs that are different shades of gray. Whereas if you're just looking at the brain window, and the brain is just the brain. So your level, you put it around soft tissue, which is 30, but then you make your width much narrower so that you can have much like bigger differences in all these different shades of gray, and you can pick up like strokes more easily. All right, next, going back to chest x-rays, they want to talk about localizing pathology. So the main concept here is with the concept of silhouette signs. So if you look at this, you think, where's the consolidation? In this case, the consolidation, you can look at the lateral, see if that helps you. So the consolidation is in the left upper lobe. So it's in the lingula. Some of you might be confused. How did you figure out that was the lingula? So it's really hard to localize lobes on a frontal view. You can't know on a frontal view alone. That's why you'll see in reports when it's just like an AP that, oh, there's a consolidation in the upper, mid, or lower lung zone, because it's just a zone and not a lobe. And a lateral will help, and I'll show you why. So for example, this is the right lower lobe, right middle lobe, and right upper lobe. So you can see on the lateral, you can see it all well demarcated, but on the frontal, they all overlap. So how do you really know which lobe you're in? You can only comment on the zone. And then similarly on the left side, overlap as well. So what can help you figure out which lobe something might be in is based on the concept of the silhouette sign, which is basically that if two objects are of the same radiographic density, touch each other, the edge between them disappears. So this is a basic image of a heart and the diaphragm. So if I have a consolidation right here floating in the middle of the lung, I can see it very well. Whereas if it's touching the heart, then the edge between them disappears. Whereas if it's at the edge that's right sitting on top of the diaphragm, then the edge between the diaphragm and the lung also disappears. So that can help us figure out, for example, which diaphragm corresponds to the left on the right if we look at it on a lateral. So this is just a lateral. We're focusing on just the diaphragm. And you can see here, I labeled the right and left in black and green respectively. And so because the heart is sitting on the left side, so you're not going to, the density or the border between the left hemidiaphragm and the heart is going to disappear. So you can see the heart here and the left hemidiaphragm, and then it sort of disappears. And that's how you know this is the left hemidiaphragm. And then versus on the right, you can trace it all the way through. Okay, and so you can apply the similar concept to localizing pathology based on what border disappears. So if this part disappears, you're like, okay, it's the right lower lobe. Whereas if this border, it's the medial right middle lobe, and so on. So here are some quick fire examples. So like, where is this consolidation? So the left heart border is obscured, like you really don't see it involved at all. So you would say that involved lobe is the lingula of the left upper lobe. And this is the CT correlate. And then how about this one? So in this case, the right hemidiaphragm is obscured. So the involved lobe here would be the right lower lobe. And over here, it looks like the right heart border is obscured. So it's a medial right middle lobe. And that's what the CT correlate is. And over here, what's gone? So it looks like both the right heart border and the right heart hemidiaphragm are obscured. So the involved lobe is both the right middle and right lower lobe, because remember, you can have like multifocal pneumonia. And over here, this is one is a little tricky one. So you might think, okay, it's sort of in the middle. So is it the right middle lobe? But actually a hint here is there's nothing obscured, but you can see the minor fissure very clearly. And that is what tells you that, okay, it's not involving the right upper or right middle lobe, which is where the minor fissure sits. And actually what is involved is the superior segment of the right lower lobe. So there's actually a lot of information on these chest x-rays. You just have to look at it carefully. And just so you know, aspiration pneumonia mostly involves the right lower lobe, but it depends on the patient positioning when they aspirated. Okay, next, we're going to go over pulmonary edema. And the way I want you to conceptualize it is what happens in a flood. So in order to understand this, you need to understand what is the functional unit of the lung is, which is the secondary pulmonary lobule. So essentially, you follow the bronchi all the way down to the very ends, and the pulmonary arteries, they branch into these alveoli. And then you have the pulmonary veins and lymphatics, which are sort of in the interstitium around it. Okay, so you can have different types of, and this is just like a graphic of it, and you can have different types of pathology, whether it involves just the air spaces or the alveoli, or if it involves the interstitium or both. So if you have filling of the air spaces or the alveoli, you think about what it could be filled with. So it could be filled with fluid in the case of pulmonary edema, blood in the case of pulmonary hemorrhage, gastric juices in aspiration, inflammatory exudate in pneumonia, water if the patient nearly drowned. It could be cancer, protein. Knowing the acuity of the development is really helpful, and also comparing to priors to help you establish a better differential. And basically what you end up with is this like fluffy, hazy airspace opacities that look like they're sort of merging onto each other. And sometimes you can see something called like air bronchograms, where basically the air spaces are filled with stuff, but then the bronchi are clear, so then you get that contrast. And I'm not really going to go over this, but you can also see interstitial disease, similar types of situation where you have pneumonia, or if you have fibrosis. And you can see that this is very different in appearance, and the normal lung that's not involved, you can, there's a big differentiation. So back to pulmonary edema. So we are thinking about vessels. Something important to note is you see up here, I drew circles for you to look at what the vessels look like in this area. So you can see the pulmonary vessels much clearer than in the lower zones of the lung versus the upper lung zones. And that will be helpful. So pulmonary edema sort of goes in processes. So you first start with redistribution. If you think, for example, in a case of heart failure with reduced ejection fraction, if you're not able to push fluid or blood forward, then it's sort of going to back up. And then how much it backs up results in how much of the pulmonary edema you see. So if it just backs up into like the pulmonary veins, then you might see cephalization. So these vessels up top are prominent, when in the slide before I showed you, you don't really see them very well. You have the arteries to bronchial ratio, maybe disproportionate. They should be about the same size. You might have a broad vascular pedicle, which is basically your aorta and your SVC. It's slightly wider than you would expect. You might have cardiomegaly and so on. But as you progress, then there's more and more fluid that gets into that interstitium because it's backing up from down the pulmonary veins. And what you end up seeing is something called peribronchial cupping, which is just like the vessels being very congested, but the like the little bronchi that are running with it are still filled with air. So then it just sort of looks like a donut, where it's like surrounded by a donut of fluid. You might see curly B signs or curly B lines, which is also fluid just in the interstitium. You might see fluid in the fissures. You may see a pleural effusion. And if that continues to be filled with fluid, eventually it's going to just back up into the air spaces and into the alveoli. So then that's when we end up with alveolar edema. And that's when you see consolidations, and you may see air bronchograms. The heart looks enlarged. You have some fluid, some pleural effusion as well going on. And another thing to know to figure out is this pulmonary edema is that they will respond after treatment pretty markedly. And over the course of several days, you'll see that this is so much clearer than the original. Next, we're going to go over pleural effusions, and the concept for this is water in a bag. That's all you have to think about to understand this. So lungs, they're sort of sitting within the pleura. They're surrounded by pleura. There's the visceral pleura, and there's the parietal pleura, and there's that potential space between it that's the pleural space, and it can be filled with stuff. If it's filled with air, we call it a pneumothorax. If it's filled with fluid, it'd be depending what type of fluid it is. Serous fluid would be a pleural effusion, blood, hemothorax, purulent fluid, and empyema. If it's mixed air and fluid, it'd be hydropneumothorax. So the formation of effusion, this is an example of this little stick figure with their purple lung airbags. And it's shown here, when they're sitting upright or semi-erect, when you accumulate fluid, it's going to be at the bottom, right? So that's what you're going to see. You end up with something called a meniscus sign, just because of physics, elastic recoil of the lungs that causes the pleural fluid to rise higher along the lateral margin of the thorax. So this is an example if it's clear, and then you have a meniscus sign. So there's just like fluid tracking along the sides. You might also see some fluid within the fissures, and then if you accumulate more, then right, you'll see it much better. So usually you need around like, take these numbers with a grain of salt, but you need around like 75 cc's to have the blunting of these cost-of-running angles on a lateral view, and at least like 300 cc's to blunt on a frontal view. So just because you don't see it on a frontal doesn't necessarily mean it's not there. And it looks different if it's supine, because if you imagine water in a bag, if it's straight up, it'll just be at the bottom, right? But then if you turn it and the patient's laying down, it's just going to look like a hazy mess. And that's what this is. So this patient was imaged minutes apart. This was when they were laying more flat, and this was when they were more upright. So you might think, wow, they improved significantly, but it was a difference of minutes. It really didn't change at all. It was just a redistribution of the fluid. All right, next we're going to go through the concept of the idea of atelectasis. And to understand this, all you have to know is when things collapse, they pull, okay? So atelectasis is when you have loss of lung volume. So that is collapse due to decreased aeration. The main ones you're going to encounter is obstructive, where something is like blocking airflow into an area, and then it just collapses. Or passive, for example, if you have a pleural effusion and sort of like pressing on the lungs, and then the lungs that are like right next to the effusion might just be like a little flattened and pushed up. So it's the same effect, but they're managed differently, as you can imagine. I won't go into the details. I just want you to see here, these are the lobes in a frontal and lateral schematic that shows if they collapsed, which way it collapses. So for example, right upper lobe on the lateral, it looks like it closes like a fan. On the frontal, it pulls things upwards. And this will be helpful when you're looking at imaging to figure out what's going on. Other direct signs you would have is fissures being displaced. You can imagine if the right upper lobe is being collapsed and it like collapses upwards, it's going to pull the minor fissure up with it. You may see vascular crowding. Some indirect signs you might see is that the diaphragm might be slightly elevated, the hilum might be displaced, you might have some rib crowding on the side with volume loss. If it's significant, there might be a slight mediastinal shift or pull to the side with the volume loss, and you may have overinflation or compensatory inflation of adjacent or contralateral lobes. So in this case, what do you think is the most likely diagnosis? So this diagnosis here, because we're in the section, it's atelectasis. So now you have to figure out which lung lobe is involved. So this is tricky if you haven't looked at many chest x-rays, but this is actually the left upper lobe. And this is an example of a Luftsickle sign. It's like an air sickle is the translation from German. So basically what it is that the left upper lobe is collapsed and there's compensatory hyperinflation of the left lower lobe, and that's sort of like the air that you see around the aortic knob. And if you get a lateral, you can see that as well, that this fissure over here is pulled it's not supposed to be all the way up here, but it's pulled all the way up, and the left upper lobe is just like collapsed. Crazy stuff. And then, so this is an example of a right upper lobe atelectasis. This specific example is we call the reverse S sign of Golden, because the red arrows are pointing to the right upper lobe collapse itself. It's a straight line. As I said, it collapses upwards. On the lateral, it collapses like a fan. So this line is actually the minor fissure, but the reverse S sign of Golden, so this is a reverse S, refers to there being a mass in this area. So if it was just plain old collapse, this is what it would look like on the right side of this inset photo. Whereas if you have a mass here that might be causing the obstruction that caused the right upper lobe collapse, that is when you would see the S. When you have left lower lobe collapse, you have something called a flat waist sign. So this yellow arrow is showing the normal left heart border, and then there's just additional straight line that's here. And why would you have another diagonal line behind the heart? And that's because the left lower lobe is collapsed. And you can also see that here on the lateral with the arrows pointing towards it. So you have the flattened heart border, downward shift of the hilar structures, and the heart looks a little rotated. Next, now that we've gone over all of that, we can talk about an opacified hemithorax. So what is your differential for an opacified hemithorax? So it could be pneumonia, it could be atelectasis, it could be pleural effusion, pneumonectomy. These all seem like they probably look the same, right? But, and you can have more than one problem, but there are actually hints that you can figure out which is which. And the way I like to think about this is, are structures being pushed or are they being pulled? So in atelectasis, remember I said that things collapsing will pull things towards it. So as you can see here, this white arrow is showing, although this is a opacified left hemithorax, the trachea is not quite midline. It seems to be pulled slightly towards the opacified hemithorax. And then this black arrow here is pointing towards the right heart border, which normally we would see like overlying like the right border of the vertebral bodies, but it's like all the way over here. Whereas in a pleural effusion, you're filling the pleura with fluid, and so that's going to be pushing stuff away from it. So in this case, you see that the trachea is pushed away from the fusion, and the heart is also further lateral than you would expect. Whereas in the case of pneumonia, it's just filling in the air spaces. It's not actually filling like the hemithorax, and it's not collapsing anything. You do have a little bit of collapse when you like fill the airspace with junk, but it's not so significant that you would expect structures to be pushed or pulled. So we just say it's neutral, and you can see trachea midline, right heart border. And in patients who have a pneumonectomy, basically when they take out a lung, for example, if they have cancer, so this is 24 hours after removing the lung for carcinoma. So you can see that things are pulled because they're just like filling up this empty space. Over several weeks, the space eventually filled in with fluid, and then the body adjusts and the heart and the mediastinal structures will shift to fill in the empty room. So sorry, so this inset here is referring to the immediate post-op, and this would be much later. And then finally, the concept of pneumothorax is just understanding that air rises. Okay, so is there a pneumothorax here? Kind of hard to see. Sort of search the heart borders, the thorax borders, and you're going to say, yes, it's a hydropneumothorax. Why? It's because you see that there is actually, this is very subtle, hard to see maybe on your slides, but you can see like a border here. That's like the lungs. This is darker than the right side. And there's, for some reason, there's like a horizontal line here, and you're not supposed to have a random horizontal line across the thorax unless you have fluid there, which is why we call it hydropneumothorax. So really the definition for a pneumothorax is when you have this visceral pleural line that you can clearly demarcate. It runs parallel to the contour of the chest wall, and you have absent lung markings distal to this area. So in this case, does this patient have a pneumothorax? So it kind of looks, is that something that's running parallel to the thoracic wall? Is there lung markings beyond that? So the answer is no. They got a CT, it was totally normal. So there are lots of fake outs that can look like pneumothoraces. So you can have skin folds, the medial edge of your scapula, you have absent lung markings in the case of bullae and cyst. So this patient has severe bullous disease, and it looks like they have a pneumothorax, but that's just a huge bulla. Or in this case, this patient, it's just like the scapula, or here is just their skin fold. And if you readjust and take another image, it'll probably be gone. In this case, this patient have a pneumothorax? The answer is yes. This is a deep sulcus sign. And what you can know is that air rises. So usually we look at X-rays which are erect, and then the air will rise to the top. That's why we usually check the top part. But if a patient is laying supine, and the supine abdominal radiograph is also going to rise to the top, but now the top is a different area. And that's going to be this area along the sulcus. And that's where you'll see this, what we call a deep sulcus sign. And finally, the question of, should I place a chest tube? Whether you choose to ask your radiologist, or if the radiologist is wondering, should I comment on this? Really, this is a clinical decision. It's based on the patient's clinical status, and it's not a radiographic decision unless you have a tension pneumothorax. And that's the case when you have mediastinal structures which are shifted away from the side of the pneumothorax. You see this trachea is all the way down to the right, and you also have flattening of the hemidiaphragm or the heart contour by the side that's under tension, which is what we see over here as well. So great job. That was a whirlwind tour, but now you know the basics of how to systematically interpret chest x-rays. If you have any questions, you just feel free to drop it in the chat, and we'll take a short break before moving on to part 2 with Jen.
Thanks, Ying. That was great. All right, let's just take a 3-minute break. So we'll come back and start at 2:50 with abdominal radiographs and the brain. All right, we are going to go ahead and get started. I want to start by saying that I encourage everyone to put some comments in the chat. If you have any questions, please feel free to put them there. I might not be able to see them since I'll be presenting, but Ying and John can try to answer them. That's really the only way that we know we're getting to you and answering what you want. So please feel free to put them in the chat, and you can message us directly if you don't want to send to everyone, or you can just message everyone. Okay, so here's what we are going to talk about. We're talking about the abdomen and head. Just for the outline of our abdomen, we're doing radiographs first, then small bowel follow through, then CT. Okay, so in an abdominal radiograph, it's important to consider the patient positioning. There are three main ways that we obtain abdominal radiographs. The first is an upright radiograph in which the patient's standing, and then the x-rays come out and shoot through that patient from anterior to posterior. You can see this is a typical normal upright radiograph. You can also get a supine radiograph, which has several of the limitations, same limitations that Ying talked about on a chest. Here you can see the patient's laying down. Again, the x-ray tube is in front of them, and the x-rays are shooting from anterior to posterior. And this has some implications for what your organs and what pathology can look like. And the last one we talk about is a lateral decubitus. In this case, this is the left lateral decubitus, in which the patient is laying on their left side. And again, the x-ray tube is in front of them, x-rays shooting from anterior to posterior. Here you can see the table is on the left side of the patient, and they're kind of laying on their left side. You can kind of see that this side's getting more smushed than this side. Okay, it is important, like Ying mentioned, to have a systematic approach to everything that you do in radiology. Abdominal radiographs are no different. So one of the typical mnemonics that people like to use is ABDOX, ABDOX, which is described here. The way that I mostly look at abdominal radiographs is to first talk about lines and tubes, and then I look at all the dark stuff. So that includes like looking at the bowel gas pattern. I look for evidence of free air, and then I look at all the bright stuff, which would be like bones. And then I look at I look to see if there are any calcifications, and then I just kind of scan through everything else. So it's really up to you on how you want to create your approach, but it's whatever makes the most sense to you. Just make sure you are systematic every time. All right, abdominal radiographs in general are really only good for a few things. These are the four major things that I think about. We'll talk about each of them a little bit, starting with lines and tubes. So enteric tubes, there's multiple types of enteric tubes, but there's two main ones. The first one is called a Salem sump, or what we just usually describe as an NG or an OG, like suction tube. It mostly is used to suction contents out of the stomach. I think sometimes it can be used to bolus things, but mostly that's used to suction. And then you also have a Dopphoff tube or a small bore feeding tube. There are differences in exactly what they look like. Dopphoffs often have a weighted tip at the end of them that looks a little bit different, but both of these are typically used for feeding or like enteral administration of stuff. So that has implications for what it looks like on a chest x-ray or on an abdominal radiograph. So here you can see this would be the suction type tube. So this is the radiodense line that's made by the manufacturer going down the esophagus through the GE junction into the stomach. It's kind of looped in the stomach on itself. And notice there's this radio opaque, or there's this radiolucent gap here that indicates the side hole, which is made, the most proximal side hole, which is made to indicate that's where the most proximal side hole is. And then there's other holes that are in the tube more distal to that. So there's holes along the tube from this side hole to the tip. Compare that to a feeding tube in which there's no side holes. There's just a hole at the end of the tube. And so here you don't have a side hole, but the question is, where's the tip? So in this case, the tip is in the stomach for this feeding tube. And here the NG tube or the suction tube is also in the stomach. Okay, so just getting an idea of what normal positioning looks like. Here you have an enteric tube that's entering the esophagus, going through the GE junction, and then terminating in the left upper quadrant, projecting over the stomach, which is very appropriate in this case. Here's just some anatomical annotations. So here's another example. In this case, this person has this tube. Again, you can see it's coursing in the left upper quadrant, and then it's crossing midline. And then it sits in the right upper quadrant for a little bit, and then it crosses back across midline into the left hemiabdomen. So in this case, think about what normal anatomy looks like in your upper abdomen, and you would know that your duodenum takes that exact course. So here's the duodenum overlaid on here. You can see the first portion, second portion, third portion, and then it becomes the fourth portion and jejunum. So here the enteric tube or the feeding tube is probably located really at like the distal end of the duodenum, probably distal duodenum or proximal jejunum. But really just thinking about the way that you identify where enteric tubes are located is to think about anatomy and what the expected course is of what you know. All right, we get this question a lot. The question is the tip, can I use whatever the feeding tube or whatever line has been placed? So on radiology or on radiographs, we can confirm where we think the tube is located or where it's projecting over, but we don't know whether it's working or not. So I can't tell you whether that thing is aspirating or flushing or whether it's exactly in the right spot. I can just tell you that anatomically, it looks like it is projecting over the stomach. So we'll tell you where it's projecting over, and then it's kind of up to the clinical team to decide whether it's something that they can use or not. All right, so just a few example cases. This is an example of an enteric tube, and I want you to tell me where it's located. Okay, here you can see that the side hole, this was the side hole right here, which demarcates the most proximal side hole. And you can see the line and side hole are basically in the mid to distal esophagus. So this would be a little bit too high and we'd recommend advancing. Okay, here's another example. Okay, here you can see this line, this radiodense line that's coming down the esophagus, doing pretty good. And then all of a sudden it loops back on itself and the tip of it is in the upper esophagus. So in this case, this is an enteric tube that's looped and definitely should be adjusted before using. Okay, and then the last example. So normally enteric tubes should stay pretty midline because the esophagus is a midline structure and then continue on to the left upper quadrant. In this case, this line is going down midline and then all of a sudden it's taking a turn towards the right and then looping back on itself and then going off towards the left. This is an example of a feeding tube that loops in the right main bronchus and then goes back across into the left lower lobe bronchus. So this is definitely abnormal and definitely this patient should definitely not be fed through this tube. So really for lines and tubes, the goal is to know your anatomy, think about where that tube is going anatomically, and then figure out where the tip or side hole is. Okay, so just talking about some key findings on abdominal radiographs. I'm going to ask you a series of questions and you can kind of just think about it, or you can put it in the chat if you want, what you think the answer is. But this question is asking what's the most likely diagnosis? Okay, so this person does have an enteric tube. You can see it's coming down midline, crossing GE junction, and sitting basically over the stomach. And then they also have this strange thing over here, this radiodense object that's in the right lower quadrant. It doesn't look like anything that should be there. So this is a retained foreign body. This is a typical appearance of a laparoscopic sponge. And there's a radiodense marker that's put in here by the manufacturer so that we can see it on an X-ray. So this is definitely an abnormality that means that they left a sponge in there when they were doing surgery. Okay, and this is just a fun case of a swallowed foreign body. This person got an abdominal radiograph. I guess they think you can tell what those are. Those are a set of earbuds. I think they're probably AirPods, but can't quite tell. But that's an expensive meal. All right. And then this one, what's the most likely diagnosis in this case? All right, in this case, you can see this is an infant. You can see it's a pretty small person that we're imaging. And you kind of just see this like lucency laying over the abdomen. If I gave you a different image, in this case, the baby has now been placed right lateral to cubitus. Now, all of a sudden, you can see that all that lucency you were seeing over the abdomen projects over the left hemiabdomen since the patient's now laying on their right. So this is a case of pneumoperitoneum or free air. So you can see how useful a lateral decubitus would be, because just like Ying said, the concept of air rising is an important idea. So on a supine radiograph, air is rising anteriorly, and so it's hard to see overlaid on top of all the other soft tissue. Whereas on a lateral decubitus, you kind of push all the soft tissue down to one direction, and then the air you can very clearly see along the opposite direction. Okay, so this is just what we talked about. Air rises non-dependently. So think about how your patient was positioned when the radiograph was obtained. And then there's a bunch of signs that are evident in free air. These are just a few examples. So this would be a continuous diaphragm sign where you see some air underneath the hemidiaphragms here and here. And then you can see the middle part of the diaphragm here, which you should not be able to see. And then this example is the football sign. Here you can see free air that is outlining this radiodense line or this radio-opaque line, and that line is the falciform ligament. So there's a bunch of other signs, but just think about where air is going, where air should be in whatever position the patient is in. All right, and then the people love getting abdominal radiographs for small bowel obstruction versus ileus, which is in the differential for dilated bowel loops. There's the classic 369 rule, which is really just a guideline, which is that small bowel loops should be less than 3 centimeters in diameter, large bowel should be less than 6 centimeters, and then the cecum and sigmoid should be less than 9 centimeters. Those aren't set numbers, but just kind of guidelines for whether bowel loops are too big. But here you can see on image on screen left, you see these multiple dilated central small bowel loops, and then there's relatively a paucity of gas peripherally, whereas over here you just see diffuse gaseous distension of multiple bowel loops throughout the abdomen. So this is the case, so screen left is a case of small bowel obstruction, where you have centrally dilated small bowel loops and not really bowel loops distally that are dilated. And then screen right is a case of ileus, in which you have diffuse gaseous distension of both small and large bowel. Another clue that people like to talk about, although I'm not really sure how helpful it is, but people like to talk about in SBO, you can have short air fluid levels at multiple levels of height. And then in ileus, they describe these like longer air fluid levels. I don't really know how helpful that is. Probably the key takeaway is to say that radiographs are actually really bad at identifying SBO. And it's sometimes really, really hard to tell the difference between SBO and ileus on an X-ray. And truthfully, the clinical history or exam is probably the most useful. But when in doubt, you can always send them to get a CT, and that can help us differentiate between SBO and ileus. All right, so just as an example of how difficult it can be, in this case, you'd wonder, is there an SBO? Or the question would come in of whether there's an SBO. It doesn't really look like it. There's just like, a non-specific gas pattern. There's some small pockets of gas everywhere. But then they got a CT, and you can see that there are these multiple dilated small bowel loops. So the answer is that they did have a small bowel obstruction, but the reason you can't really see it that well on an abdominal radiograph is because the bowel loops are filled with fluid, not air. So we don't see the darkness of the air on an abdominal radiograph, then it can be difficult for us to identify an SBO. Okay, so this is what we talked about for some key findings of radiopaque. We talked about radiopaque foreign bodies, we talked about pneumoperitoneum, and we talked about SBO versus ileus. All right, the next thing we'll briefly touch on is small bowel follow-throughs. Small bowel follow-throughs are obtained to look for SBOs or to evaluate them. You start with a scout image, you give some PO contrast, and then you take images at multiple intervals, less than 24 hours, to look for contrast in the cecum. Normal small bowel transit time is 30 to 120 minutes. And the idea of a small bowel follow through is that if you have contrast in your colon at 24 hours, it predicts resolution of your SBO with pretty high sensitivity and specificity. So just as an example, here's a scout image just to start, just to make sure that there's no other radiodense stuff that would get in the way of interpreting your abdominal radiographs. This is an image obtained at 1 hour. So you can see that contrast was administered orally. You have contrast in your stomach as well as in your small bowel, but not yet in your colon. And so another radiograph was obtained at 5 hours. And now you can see that there's contrast that is in your large bowel and your colon along the periphery. So the small bowel follow through was terminated at this time. And this basically means that there's no high grade small bowel obstruction because contrast is able to make it from your small bowel to your large bowel. So that's the concept of an SBFT. Okay, all right, moving on to CT abdomen pelvis. All right, a CT abdomen pelvis has multiple phases of contrast that can be obtained. You can start with an IV contrast. For IV contrast, you can start with a non-con study, which would be here. So no contrast is given. This is often useful in cases of looking for things like a stone, which is typically bright on a CT. Or if you have, if the patient has chronic kidney disease or acute kidney disease and they have a low GFR, then often they cannot get contrast. And so you're stuck with getting a non-con. This on the top right corner shows us a late arterial phase. The late arterial phase is useful in evaluating things like a bleed. It can also be useful for being able to characterize a mass, such as an HCC. Bottom left is portal venous phase, which is the standard phase that we get. So this is like if you were to order a CT abdomen pelvis with contrast, you'd get it in a standard phase or in the portal venous phase. So this is what we typically use. It's the best for looking at organ enhancement, infection, inflammation, things like that. That's why we usually use it, but it can also be used to evaluate a mass. And then lastly, in the bottom right corner, this is an example of a delayed phase. So now we've waited for contrast to get into the renal, into the excretory system. Here you can see it in the collecting system of the kidneys. So this is useful if you're trying to evaluate for a ureteral or a bladder injury. You can imagine putting your contrast into the place that you want to see would be helpful. And then you can also use it to evaluate a mass. So for example, an HCC protocol or hepatocellular carcinoma protocol would be a late arterial, portal venous, and delayed phase images to give you an idea of what the mass is doing with the contrast. All right, and then this is an example. We can also, in addition to IV contrast, we can also give PO contrast. So you can have the patient drink contrast. There's two types that we can give. This one on screen left is negative oral contrast, which basically just means that it looks like fluid. So you can see this darker fluid that's distending bowel loops. This is useful for evaluating the wall of the bowel. So this is often given in a case of an enterography to look for IBD. And then screen right is showing you a case of positive oral contrast. So you can see that this person has bright stuff in the lumen of their bowel. And so this is useful for looking at things like a leak or looking for any contrast that's getting out of the peritoneum or out of the lumen. All right, reading a CT abdomen pelvis is a long process and it takes many years to learn. That's why we're all in radiology residency. But basically the idea is that there's a lot of different approaches, just like everything else in radiology, but the most important thing is to be systematic. Most people use an organ-based approach. So it'll be things like you go through the liver, you go through the gallbladder, spleen, pancreas, adrenals, and you just like check things off the checklist. There are many resources that you can look at online. Us going through the systematic approach that we use is probably outside the scope of this talk, but this is a great example. LearnAbdominal.com has this great YouTube video that goes through a search pattern and kind of things that we think about when we're reporting CT abdomen pelvis. So if you're interested in learning more, I'd recommend going there. Okay, so we're just going to talk about a few key findings on a CT. So this is an example of fat stranding. Fat stranding basically indicates this like haziness or this white stuff that gets into what should be clean fat. So this is all the same visceral fat, subcutaneous fat, and this base should look just like this. When you have fat stranding, it basically means that you have inflammation around whatever the structure is that's that the fat stranding is around. And it's a clue to us that pathology is located there. So it's non-specific itself. It's not really a diagnosis. It just helps clue you in to where you should look for pathology. So in this case, this is the appendix that's dilated, and then you have fat stranding around it. So this is the case of appendicitis. A few other examples of fat stranding. So this is the gallbladder that's really dilated. You have some fat stranding adjacent to it, basically suggesting there's inflammation around your gallbladder, in this case of cholecystitis. And then here you have the pancreas that looks inflamed and edematous, and then around it you have fat stranding in the peripancreatic space. So this is an example of pancreatitis. So that's the key point with fat stranding is it's just this non-specific inflammation that helps clue you in to the what you should look for. All right, this is just a question about a key finding, a major finding that you should not miss. The question is, what would you do? All right, great. So this is a gigantic abdominal aortic aneurysm. And the key point here is not just to identify the abdominal aortic aneurysm, but also to see that there's all this like gray stuff sitting in your abdomen that should not be there. Normally, you know, you have the rest of your organs, you have fat, here's some bowel loops, but all of this stuff is hemorrhage. So this is not just an abdominal aortic aneurysm. This is a ruptured abdominal aortic aneurysm, which is, you know, aneurysms are very dangerous, but a ruptured abdominal aortic aneurysm is like, you know, they need to be in the OR yesterday. So the answer here is to stop page vascular and let them deal with it. Okay. There's hemorrhage. All right, this question, what would you do next? All right, this one can be a little bit hard to see, but this brings up the concept that Ying kind of mentioned about windowing. So if you switch this is a soft tissue window. If you switch the window to a lung window in which air shows up really, really dark compared to everything else, now you can see all of a sudden that there's air that's outside your lumen, outside your bowel lumen. And so this is an example of free air. Most commonly, that's a result of bowel perforation. And so it's important to call surgery to let them know that they should probably take this person to the OR. But the concept here for us is to know that lung windows can be useful for looking for free air. So whenever you're looking in the abdomen, you can consider changing it to lung windows. All right, so just some things we talked about in the abdomen and pelvis. We talked about fat stranding, we talked about a ruptured abdominal aortic aneurysm, and we talked about free air. There are many, many, many other things that we talk about on CT, but we do not have time for all that today, so we are going to move ahead. All right, moving on to neuro. Okay, here's our outline. We're going to start by talking about the CT head. We're going to talk about intracranial blood, MRI sequences, and then hood strokes. All right, so a very basic approach to looking at head CTs. You have an axial plane, coronal plane, and sagittal plane. It is important to look at all planes because there are some things that are better identified on a coronal or a sagittal compared to just the axial. So for example, it's often easiest to see midline shift on a coronal, often easiest to see subdural hemorrhages along the lateral convexities on a coronal, often easiest to see the pituitary and the midline structures on a sagittal. So it's important to use all planes. The second thing is to understand that symmetry is your friend. So most of the time in the brain, you can look at both sides to make sure they look the same. There are some processes that involve both sides, and so that's not always the case, but for the most part, you can use symmetry as your friend. And then these are just some of the key concepts that we look for. You should look for blood. You should look for whether your ventricles are big. You should look for mass effect or midline shift to see if there's a mass that's somewhere. And then you should look at the gray-white differentiation. Again, the scope of this talk just can't include a full approach to a head CT, but again, there are resources online that can be helpful. Okay, so we'll just talk about intracranial hemorrhage since this is one of the main things that people look for on a CT head. So these are two examples of different kinds of intracranial blood. Okay, so on screen left, you have a subdural collection, and then on screen right is an epidural collection. And the difference here is that subdurals look like bananas. So they are crescentic or convex in shape. They often are a result of, sorry, this is backwards. This should go over here and this should go over here. I'm sorry about that. So this is a concave subdural collection. That's usually a result of a bridging vein. There's usually no calvarial fracture, and this is in older people. Sorry, this should be switched. And then an epidural collection is convex or lenticular, often described as a lemon shape. It's usually a result of middle meningeal artery injury. And then often there's an overlying calvarial fracture. And then classically, people describe clinically that there's a lucid interval. So they're awake for a little and then they pass out again and then they wake up again. Okay. These are three other examples of types of intracranial hemorrhage. So in this image, you have this large area of hyperdensity in the brain, in the parietal lobe. This would be an example of an intraparenchymal hemorrhage, most commonly a result of hypertension or amyloid. In this middle box, you have all these linear or curvilinear areas of hyperdensity. This would be an example of subarachnoid hemorrhage, which is usually a result of aneurysm or trauma. It's important to look for the complications of hydrocephalus or vasospasm. And classically, the clinical scenario is a thunderclap headache. And then finally, this is a case of intraventricular hemorrhage. So here you can see the ventricles, and then there's this white stuff that's in them. That is blood in the ventricles, most commonly due to hypertension and aneurysm or extension from like an intraparenchymal bleed. And again, it's important to watch for hydrocephalus because that blood can clot and obstruct your ability for CSF to flow freely. Okay, so this is just a diagram of the different types of intracranial blood that we've talked about. So just think about your anatomy of knowing the parts of your brain or the parts of your intracranial structures and figuring out where that blood is located. All right. We're then now going to talk briefly about MRI sequences. There's a bunch of different MRI sequences. When you obtain an MRI, we have protocols. So we obtain multiple sequences all at once. You, as an ordering physician, will not have to tell us which sequence to obtain, but there are certain concepts that are helpful for you all to know when you're trying to look at MRIs on your own. And so this is an example of, so we'll just go through a bunch of different sequences, a bunch of the basic sequences. So here's the first one. And I'm going to give you a little bit to think about it. Okay, so in this case, the most important thing to think about is what color is the white matter and what color is the gray matter. So in this case, this is the white matter. It is whiter than the gray matter or the cortex. So you can see the cortex as the rim all around the white matter. So white is white, gray is gray. And then CSF in the ventricles is dark. So this is an example of a T1, which is really good for anatomy. And basically, I think of it as it looks just like anatomy. So we know that white matter is white, gray matter is gray. White matter is brighter than gray matter, and CSF is dark. Okay, here's the next sequence. Okay, on this sequence, you can see that white matter is now darker than gray matter, right? So you have white matter's dark, gray matter's bright, and CSF is bright. So this would be an example of a T2. So here, white matter's dark, gray matter's bright, CSF is bright. All right, and then this is the one that always confuses people, which is why I bring up the difference between white matter and gray matter as the most important thing to look at. So if you look at the white matter and gray matter here, the white matter is dark and the gray matter is bright. So this relationship means that this is not a T1, even though CSF is dark. So this tells you that this is a T2 weighted sequence, in this case, a flare, because they have suppressed the CSF. Normally CSF is bright in T2, but here they've taken all the CSF and made it dark. But the gray and white differentiation is the same as on a T2 weighted sequence. So the first thing you should look at when you're looking at a sequence is to look at white matter and gray matter to see what the comparison is between the two. And then you can look at CSF if you want to. Okay, here's a T1 for comparison. Again, note that CSF is dark in both, so you can't use that as the differentiation. You have to look at white matter is white, gray matter is gray in a T1, and white matter is dark and gray matter is white in a flare or a T2. Okay, here's the next sequence. Okay, in this case, this is a post-contrast T1. Whenever we obtain a post-contrast study, it's usually T1. There's very rare instances that we do a flare in kids, but mostly we do T1. But here you can see that vessels are bright. So this is the dural venous sinuses that are showing up bright. And so that means that there's contrast in all these vessels. This is a post-contrast T1. The other thing that people like to talk about in the brain is that the nose knows, and that by that they mean that the nasal mucosa enhances on a post-contrast image. So here's a non-con T1, and here's a post-con T1. You can see that the nasal mucosa has gotten brighter on a post-con, and so that's one of the ways you can tell that this is a post-contrast sequence and this is a non-con sequence. All right, these two are put side by side. Okay, and on these two sequences, you can see that there's pretty poor resolution. That's the thing that strikes me first, is that there's really poor or crappy resolution of the rest of the intracranial or the brain or the cranium. You can't really see like the skin and scalp and all that stuff. You just see like brain, and it looks like not very good detail. So those are the first clues that I have to identify that what I'm looking at is either a DWI, which is in this case, and an ADC, like here. So DWI has dark CSF, whereas an ADC has bright CSF. And really you're just looking at, you're looking for restricted diffusion in these cases. The ADC is basically just the inverse. It's a calculated map of the DWI to help confirm that there's restricted diffusion. And as an example, this is a case of restricted diffusion. So if you have restricted diffusion, you are going to see a bright spot on DWI that corresponds to a dark spot on ADC. So restricted diffusion equals bright DWI, dark ADC. That is in comparison to another phenomenon that we call T2 shine through. And that is because both of these sequences are T2 weighted sequences, that means that T2 bright structures will still be bright on a DWI. So in this case, this thing is bright on DWI and it's also bright on ADC. So if you have bright DWI, bright ADC, that is the phenomenon of T2 shine through. That does not mean that it's restricted diffusion. It just means that it's bright on DWI because it's already supposed to be bright on T2. Okay, so restricted diffusion is bright on DWI and dark on ADC, whereas T2 shine through is bright on both. Okay, so this is just a practice for you all to go over the sequences that we just talked about. So this first one in the top left corner, this is a T1 because white is white, gray is gray. CSF is dark. Okay, this next one. You'll notice again, CSF is dark, but this time white is gray and gray is white. Therefore, this is a flare. This is a T2 with CSF suppression. Okay, looking at this one. On this one, you might be tempted to say that this is a T2 because the CSF is bright, but notice how you don't really have any resolution of anything else outside of the brain parenchyma. So this is an ADC. This is a poor resolution study or a poor resolution image with bright CSF. It's an ADC. This in the bottom left corner. You can see all these linear areas of bright stuff. All those things are vessels that are lighting up. So this is a post-contrast T1. This one in the middle on the bottom. CSF is dark, but again, notice how you don't really have any resolution of these structures outside of your brain parenchyma. So this is a DWI, a poor resolution study with dark CSF. And finally, bottom right corner. So here you have CSF that's bright, gray matter, white matter is gray, and gray matter is white. So this is a T2. Okay, so notice the biggest ones that people have problems with are T1 and flare, trying to differentiate the two. Most important thing is to know white matter is white and gray matter is gray in a T1. And then people often have difficulty differentiating between ADC and T2 because they just look at the CSF and say it's bright without thinking about the rest of the structures that you should be able to see on the brain. So ADC is crappier resolution, poorer resolution compared to a T2. Okay. Now you all are expert. There's many other sequences, but we just talked about the big ones. Okay, and here's just a summary table to show you what we just talked about. This is probably a gross simplification, but. All right, and then the last thing we're going to talk about is code strokes. The study that we use to evaluate this is a CT perfusion study. There are 3 parts to a CT perfusion study. The first one is a non-contrast portion. The non-contrast portion is really used just to rule out an acute bleed. So the main thing that we're looking for on a non-contrast study is ruling out an acute bleed, looking for a bright area that means that they can't get TPA. There are sometimes we can see other things, like for example, you can find in hyperdense MCA. A hyperdense MCA sign is basically indicative of a clot in the MCA. And so you see this on a non-con study. If you have a bright MCA, that suggests that there's thrombus in there, which would be like a large vessel occlusion in a stroke. So that's what we're looking for. And then you can sometimes see an established infarct. A non-con CT is not very sensitive for this, but you can see a large area of hypoattenuation in this case in the right MCA territory. That's an established infarct. But realistically, the main thing we're looking for on a non-con is to rule out an acute bleed. Okay. The second part that we get is a CTA head neck. And this is to look at the vessels of your brain and your neck. And it's to look for vascular anomalies. So if you have any kind of narrowing or duplications or occlusions or anything like that. And then in the brain, the real thing that we're looking for is large vessel occlusions. So if you all of a sudden see a cutoff, like in this case of the left MCA, that means that neurosurgery can go in there and potentially do a thrombectomy or administer TPA there or whatever it is that they do to try to open up that occlusion. So it basically gives the neurosurgeons an idea of what it is that they're trying to go after. Okay, and then the last part of a code stroke study is the perfusion portion. The perfusion portion looks like all these colorful maps, and there's all these different parameters that we can use. The main thing for you all to know is that you're looking for the penumbra volume. There's a bunch of different software that does this. This is what ours look like, and I'm not 100% sure what your institutions will look like, but this is what we're looking for. So on this left side of the image, we're looking for cerebral blood flow less than 30%. And anything that has a cerebral blood flow less than 30% will show up in pink. So here you can see that this is 25 milliliters of the brain that's showing up with CBF less than 30%. On the right side in green, all of this part of the brain has a T max or a time max greater than 6 seconds. So it's taking a longer time for contrast to get to that area. And that volume is 283 milliliters. And then it subtracts to get the mismatch volume. So 283 minus 25 is 258. Okay, so what this tells you is that the pink in this case is core infarct. This is tissue that is dead. This means that this tissue, if you were to revascularize, would not come back. This side is telling you, the green side is telling you core plus penumbra. So notice it includes the pink, but then there's other stuff around the pink. And then the subtraction of the two is the penumbra being the at-risk tissue. So theoretically, the at-risk tissue would come back to life if it was revascularized. So the neurosurgeons will use this map to determine how much of this tissue can be saved if we were to go in and do an intervention. So most of the time, the neurosurgeons just look at this map and they say, okay, if there's a large volume of penumbra, I might go in there to salvage some brain tissue. But if all of it is core infarct, then there's not really much that we're doing. Like even if I went in and revascularized, that brain would still be dead. So there really isn't as much of a point of that. So they use this map to determine that. So remember, core infarct is this pink portion, and then penumbra is the subtraction of your at-risk plus core minus just your core. Okay, and then this is just an example, the last example that I have of an infarct. So in this case, this is an MRI. This is a DWI image, poor resolution, CSF is dark. This is ADC, again, poor resolution, bright CSF. And this is a flare where white matter is gray and gray matter is whiter. So you can see that like here, and CSF is dark. So this case has a area of bright in the on DWI, area of dark on ADC, and then on flare, there's not really any signal. So this is an example of a right MCA territory infarct that's fairly acute since there's not any flare signal yet. Okay, this is what we've talked about. So we talked about abdominal radiographs being good for a few things. We talked about small bowel follow-throughs. We talked about CT abdomen pelvis and its use of contrast, as well as some important findings. We talked about intracranial hemorrhage. We talked about MRI sequences, and then we talked about a code stroke. All right, that's all my slides. So I thank you for your attention. Let me get out of that.
All right, awesome presentation, Jen. So I'll be doing the last part. We can take maybe like a couple minute break. So we can maybe start at like 1:32. Thanks. All right, let's get started. Let me go ahead and share my screen. Okay, so my name is John. I'm one of the residents at UCLA. So for the last part, I just want to kind of go over some of the, I guess, like soft skills within radiology. I'm talking about radiology workflow, what happens when radiology is on call, also different types of imaging modalities and their characteristics, what you should do when you consult IR for a procedure, and then also for those interested at the end is talking about just like what you do on your radiology rotation. So I think one of the concepts that as you progress through medical school, you start to realize there's something called a hidden curriculum. What that means basically is that, during the first 2 years, you have a lot of lectures and then you have textbooks and things like that. But there are things that to take care of patients that you do every day that's not really taught. And these things are you just, once you show up on third year rotations, kind of are just expected to know, but you don't really know it until you pick it up during the rotations. And then this is just a quote from my program director. So I did prenatal medicine for my internship. Says the best intern on day one is the one who knows where the bathroom is. So it just kind of emphasizes that concept where it's not really, sometimes it's not really about what medical knowledge you have, but also just about like knowing the workflow and knowing the logistics of the hospital. So these are just kind of like exaggerated examples of my internship year, just to help kind of navigate between the topics. So this is just imagining you showing up the first day of residency or your sub-internship. So 1 minute after signing out, your senior resident says, "Welcome to our service. I'm late for social work rounds, but Mr. X, your number 3 out of your 6 new patients, had shortness of breath last night. The CT test done overnight was negative for PE, but they did mention there's a 1.5 centimeter nodule. Can you call radiology to clarify? We need to work this up more. I don't know their extension, but it might be on the whiteboard somewhere. Thanks." And then immediately after she leaves, your pager goes off again and you get another page. And then this time it's about a different patient whose blood pressure is soft, 88/50, and then the nurse is asking if you can come assess. And by the way, her room is on a different floor than where your resident lounge is. So you have to go a little bit farther away. So at this point, you have to see 6 new patients, and you have to one patient that's slightly unstable. So basically, it's very busy. So you don't have all the time to call everyone to figure out what the number is. And you look on the whiteboard here, and it's just a lot of information, but you don't really see what the radiology information is. And then this is kind of a picture that everyone sees, the typical hospital phone. So now you have to figure out where to call. So for radiology, this is very institution dependent, but for most places it depends. Radiology reading rooms are located based on modality. Based on anatomy. So for example, chest is going to be reading types of chest imaging. So for CT chest, you would call chest, and they also obviously do chest X-rays, and also MRI chest as well. For body, these will be typically separated by different modalities. So at my institution, UCLA, body CT and chest X-ray, or sorry, abdomen X-ray is read by the same service. And then body MRI is going to be read by a different service. And then similarly, if you have any genital urinary imaging, meaning you're imaging the kidneys, ureters, or bladder, that's going to be a separate service. And for neuro, usually any like CT brain or MRI brain, that'll be read by neuro. I put this in the middle here for spine imaging. Typically, that's read by neuro in most places. Some places, however, MSK will be splitting with neuro for spine imaging. And then for MSK, obviously, any kind of extremity X-rays they'll be reading, and also MRIs for the extremities here and joints. And then breast, obviously, it's going to be any kind of mammograms, and then breast MRIs as well. For pediatrics, essentially any imaging for patients who are under the age of 18 is going to be read by by peds. With the exception of neuro, most of the time that should be read by neuro. And sometimes complex cardiac cases will be read by a different service. So here we have a chest X-ray on a peds patient, and then this is also a intracranial ultrasound. So both of these are read by peds. These other sections can be a little bit confusing. Some institutions, they have what's called an ER in the acute care section, meaning all imaging that's gone through the ED is read by the section regardless of where the anatomy is. So for example, kind of like what we talked about before, if you have chest CT, but it's coming through the ED, that's going to be read by the ER section rather than the chest section. And then we also have PET CT. So this is where a lot of the oncology imaging is read. So you have the PET portion, and this is going to be the fused PET CT portion here. Some institutions also have a cardiac section, looks at cardiac CTs, cardiac MRIs. So anything aimed to image the heart is going to be read by this section here. And finally, there's going to be an ultrasound section as well. So any kind of ultrasound done in the body, regardless of anatomy, most likely will be read by this section. So this is all to say, you know, there's a large division of radiology sections, and each one of them reads specific types of imaging. So at least here, there's separate extensions for each section, and I think this is very helpful to have. So during my internship, I kind of just made a list on my phone under the Notes app of like quick extensions for different radiology sections. I thought this was very useful in terms of you could reach the specific imaging department very quickly. And then it's also something you could do like right during the middle rounds. You know, if someone's asking you, hey, can you call radiology to clarify this? You can do that right away instead of having to wait until after rounds. So if you like wherever you go, if you can compile a list like this, it'll be very helpful. So the next section. So at 7:17 a.m., your pager beeps again. This is from the ID fellow. He's saying, Mr. K, for Mr. K, can you call IR to make sure that we get the LP done today to work up his encephalopathy? That's weird, because when you're talking to him earlier, he was ANO ×3, but actually, no, that was a different patient. So for procedures, I think traditionally people think of a divide between diagnostic radiology and interventional radiology, as in interventional radiology does all the procedures and then diagnostic radiology reads all the images. But in fact, most of the diagnostic radiology sections do procedures. And these are going to be vary based on the institution. Sometimes IR will do some of these procedures. Sometimes your individual section within radiology will do these procedures. So it's always good to check with your institution. So starting with body, kind of like what the earlier lectures were talking about, in the GI fluoro, assessing the GI tract. So this is an esophagram here. That's going to be done by a GI. Also, if your patient's got any kind of enteric tubes, so gastric tube, jejunostomy tube, things like that, that's also going to be done by GI as well. And then here, if they any kind of abscess drain, so sticking a needle into the abscess, placing a drain, and then helping that area drain, that's going to be done by GI. And then radiology also does biopsies. So we can do ultrasound guided biopsies, we can do CT guided biopsies, and we can also place and exchange nephrostomy tubes. In addition, some of the more complex procedures are also done by body imaging depending on where you are. So some places can do CT guided tumor ablations. So this is a cryoablation of a renal tumor. And then also we can insert needles for radiation oncology for brachytherapy. So this is kind of like a group approach where, you know, we use CT guidance to insert the needles, and then the next part radiation oncology takes over, and then they do their part in terms of inserting the brachytherapy treatment. Chest, like body, also does some procedures. Again, this varies by the institution, but for the most part, chest is able to do biopsies in the lungs. So any kind of mass that you do, you see, chest can biopsy. And then they can also do ablations. So you have a lung cancer here, they're able to ablate it to treat it. Neuro also does procedures. Primarily, they do lumbar punctures. So usually, typically lumbar punctures should be first attempted on the floor by the team using an anatomy landmarks. So when I was an intern, we did lumbar punctures on the floor. But if you're unable to get it or the patient's anatomy is difficult, then you can call radiology and ask them to do a lumbar puncture. So Once you do a lumbar puncture, there's additional procedures you can do. Usually, when you do a lumbar puncture, you want to take fluid out for analysis, but you can also inject contrast into the spinal canal. So in cases where you can't do MRI, if they have hardware or if there's any other contraindications for MRI, you can inject contrast into the spinal canal. This helps you see the spinal cord, and then also in axon nerves. So this is called a myelogram. You can also inject chemotherapy. So for patients who have leptomeningeal disease, you have to inject chemotherapy straight into the same area. If you just do IV chemotherapy, it's not going to get to your leptomeningeal areas. So this is something we also do as well. For MSK, similar procedures. We can access joints. So under flow guidance, we can inject into a joint, and then we can either inject corticosteroids or anesthesia medications, or we can take fluid out. So if you have a patient that's coming in and you're concerned about a second joint, we can take fluid out, just send that for analysis and growth cultures. Radiology can also do bone biopsies. So for patients with any kind of suspected marrow abnormalities, we usually can do a bone marrow biopsy under CT guidance like this. Breast, obviously, this procedures. So any kind of breast mass or concerning area can be biopsied either under ultrasound guidance or stereotactic guidance, meaning this is done under using mammograms as a guidance. So that kind of talks about different radiology section procedures. So the next, you get another page. It says the CT abdomen pelvis for Mr. P still has a prelim result. Can you please check when it will be finalized? Although you don't have Mr. P on your list and you don't know who this patient is. So this is talking about the radiology workflow here. So it kind of divides into two sections. One is going to be daytime. This is going to be what you think of as regular radiology. So in this case, every subspecialty section I talked about before is here during the day. Many of the routine procedures are done during the day as well. And this is especially relevant for ultrasound. Many technologists are here. So for ultrasound, it's the technologist that scans the patient. So more ultrasound technologies available, more exams you can do. So during the day, a lot of the exams are done. Once you go to overnight, this is when most of the people leave the hospital and go home. And then you have just a few people on call to manage the studies that come in after hours. Usually, if you're at an academic hospital, you're going to have an on-call resident. And then depending on the structure of your call system, you may or may not have an attending available as well. During this time, since there's a very skeleton crew, typically only emergent procedures are done during this time. Also, because the technologists would like to go home as well. So there's only a few technologists available on call. So during the day, you may have 8 ultrasound technologists scanning, but at night you may only have 2. So the exams may be delayed overnight. So this is kind of just talking about types of call for radiology. So I think the way I grouped it, there's 3 types of call for radiology residents. First you have what's called fully independent call. So in this case, there's only the radiology resident available. Studies are going to be prelim by them, and then once the attending comes in the morning, this is when they start reading the studies. And then for prelims, there's also different types of prelims. Some institutions will draft just say a one-liner answering a clinical question about the patient and say if there's any kind of emergent findings that you have to address. So say you get a CT abdomen pelvis. The prelim read from a resident overnight may be no bowel obstruction, and then they'll say non-acute findings will be dictated with the full report. So other things that's not emergent is going to be seen tomorrow morning. Some places do full reads, so they'll say no bowel obstruction, but now their cancer's getting worse. So this is a relevant finding, of course, but it's not an emergent finding, but it will still be dictated in the full report. Some places they do what's called a partial independent call. There's only the resident available on site, but if there's a need for emergent study to be read by attending, they do have teleradiology, meaning there's a radiology attending at a third-party company that is able to take these readings upon request. So say the resident has a study that they're not super sure about, but it's a very critical call, then they can send the study over to a teleradiology attending who will read it as needed. And then finally, you have non-independent call. So this is where you have a resident and attending on call together. So still in this case, the resident is the one reading the cases first because that's just part of the educational system for radiology residents. So once they pre-limit, the attending is going to be either they're in the same room, or most times they're in a different section of the hospital or even at a different hospital. And then they'll read the study when they're available. And usually that gets done within the hour, but at times it may take a few hours to read. So depending on where you are for training, this is going to be how the radiology on-call situation will be. And then most of the time, if there's any kind of critical or acute actionable findings, radiology is going to page you. And then they want to verbally discuss this finding to you. And then afterwards, they'll ask for your name. It's not anything that they're trying to target you or anything like that. It's just that for the purposes of the report, we're required to document who we're communicating for the report. So this is kind of a typical phrase that people just say, like, can I get your name for the report at the end of a conversation? Also, for places that do overreads, if there's a significant change to the findings, then they'll also page you too. So ideally, if there's any kind of actionable findings or changes to your exam, you're going to get a page where someone from radiology is going to talk to you. Okay, so continue on to the next section. At 7:40 a.m., you get another page. Nurse is saying, Mrs. S doesn't want to go down for the CT scan today because she doesn't want to lay flat. Can we change it to an ultrasound? Is that better? Please advise. And this was definitely not on you. So this is kind of talking about different characteristics for imaging modalities. In radiology, there's two characteristics that we generally think about. The first one is called spatial resolution. What this means is that how sharp is your image? Are you able to distinguish two adjacent structures that are next to each other? So this is kind of just a cartoon example here. So here, this is an image with high spatial resolution, meaning that, for different bones in the hand here, you can tell the difference between the space and the bone very sharply. And you can look at the edges of each bone, and you can see it's a very fine linear line where if you wanted to draw with a pencil overlaying it, you can do it very easily. So this is high spatial resolution. Here's an image with low spatial resolution. And you can tell intrinsically this is a blurry image. But to break it down to what it means in terms of spatial resolution means that, the borders are very not well defined. It's hard to tell one adjacent structure from the other. So that's spatial resolution. The next concept is contrast resolution. What this means is that the ability of the imaging modality to distinguish two tissues with similar characteristics. So here's kind of an example of two modalities. So you have A and B. So B here has higher contrast resolution, meaning that there's a black rectangle here, and then inside it there's a gray square. So for B, you can see under all three conditions here, you can distinguish that in fact there are two separate structures next to each other like this. But for A, the only time you can see it here is going to be in the middle scenario here, but in here and here, you're not really seeing two different structures. You're just seeing one kind of shade. So now thinking about those two concepts, I want you to guys just take a few seconds to think about. So these are the common imaging modalities within radiology. So you have radiograph, X-ray, ultrasound, CT, MRI, and think about what you would think the spatial and contrast resolutions for these modalities would be. And just kind of think a couple seconds in your mind, which one do you think out of these is going to be the best for spatial resolution? Which one for these is going to be the best for contrast resolution? So this is what it actually is. And sometimes I think it's very surprising for people. Typically people think of MRI as the best imaging modality, although the spatial resolution is actually only fair. And people tend to think of X-rays as kind of your screening, first line exam where, if you wanted to get more information, then you should do a CT or MRI. But in reality, the spatial resolution for an X-ray is actually really good. So below are some examples here. And then I have the chart up here again, just for reference. So this is an example for a spatial resolution. So if you look at, this is a mammogram, and then this is type of X-ray. The spatial resolution is excellent. So you have these fine microcalcifications that's within the breast, but you're able to make out every single individual one of them. And the other thing is that if you try to look at the borders, they're very sharply defined. So this is an example of high spatial resolution. And if you move to the middle here, so this is going to be ultrasound. It's going to be a little bit intermediate. And if you look at these bright spots, these are the calcifications. Most of the times you can't see calcifications, but in this case you do see a little bit. You'll see that the calcification is much more blurry around the edges, which is less spatial resolution compared to the X-ray here. And then when you go to MRI, you can't really see when you look at the border. So for the MRI, this is going to be what's called a fat suppressed image. You have fat that's dark, and then you have fibroglandular breast tissue that's bright. And you can see high contrast resolution, meaning that you can tell different types of tissue very easily. The fat and the fibroglandular breast tissue stands out very well. But if you want to look at the individual borders for the tissues, it's much more blurry. So that's the concept of low spatial resolution. Next is for contrast resolution. So again, contrast resolution just means how well can you differentiate two adjacent structures of similar tissue densities. So here we have an X-ray here. This is a X-ray of the pelvis. So if you look at the chart here, so this is excellent spatial resolution, meaning if you look at the bones here, right, you can see the borders extremely well here. But the contrast resolution is poor, meaning that, as we all know, there's different types of structures within the pelvis here. So you have your rectum, you have your bladder. This is a male patient. So then you have your prostate, you have your seminal vesicles. They're all in here. But because the contrast resolution is so poor, you can't really make out anything. You just know there's a jumble of soft tissue in this area. And then next you go to CT, which is kind of the middle modality here. So you can make out a little bit of the rectum here, but still, like this part, all these structures here, this kind of looks like a jumble of tissue. And finally, you go to MRI. So now MRI has excellent contrast resolution. So now you're able to make out all these structures very well. You can see the prostate here, the seminal vesicles adjacent to it. Even within the rectal wall, so we have the mucosa here and the rectal wall, you can see all these things as discrete entities. But again, to the spatial resolution, if you try to look for the borders of these structures, they become very blurry. So it's hard to see distinctly where one ends and the other one starts. The next thing about radiology modalities is that the timing and how long it takes to do these sections, these exams. So again, I want you guys to take a few seconds just to think about the examples I've given here is an abdominal radiograph, an ultrasound, a CT abdomen pelvis without contrast, and an MRI abdomen pelvis without contrast. Kind of just think about in your mind how long it takes to do one of these exams. And then kind of ranking in your mind which one would be the fastest to do and which one would be the slowest to do. So here's how long it takes for these to happen. So for X-rays, these are very quick. Basically the tech shoots the X-ray and then that's the entire exam. So these only take about a few seconds. For ultrasound, it's user dependent based on how fast the technologist is, but usually that would take about 30 minutes for a full ultrasound of the abdomen. For CT, I think this is the part where people think CT takes a long time, but usually it's actually pretty fast. Most of the time, it's actually just getting the patient position on the table. For non-contrast exams, pretty much you generate the field of view that you want to scan, and then the scan itself takes only a few minutes to do. So these are usually quicker than ultrasound exams. And then for MRI, it depends on the number of sequences you want. So some exams, for example, if you're doing a fibroid study, that's going to take many series. that's going to take longer. But if you're doing a hip MRI for MSK, that's only about 4 to 5 sequences, so it takes much shorter. But usually it's longer than 30 minutes. So usually MRI is going to be the one that takes the longest to do. And then for the next section, so finally you're done with all your tasks for the morning. Your senior resident comes back and they say, oh, did you call radiology about Mr. X? Anyway, can you also call IR for Mr. Y? Social work says his sniff authorization expires today, so we need to have a tunnel catheter line placed prior to discharge at 2 p.m. So again, you have your handy dandy number here, and you can see IRs here. So this will be the number you dial. So now here's some things to know when you're calling for IR for a consult. The first 3 I put in gold here because I think these things are nice to know, but this is all things that we can find in the chart. It's a good etiquette to know these things when you call for a consult, but it's not necessary. Mainly the things you want to know is that who the patient is, what's the MRN, what's your callback number in case we need to locate you and discuss more, and what procedure that you want. So even if you just kind of vomit over yourself during the conversation, you don't say anything else, as long as you communicate these 3 concepts, this is pretty much all you need. Other things that are helpful is that is the patient anticoagulated? Are they on any kind of IV or PO anticoagulation medication? Are they NPO? This is going to dictate what kind of sedation we can give them. What's their INR and what their platelet count is in terms of every procedure has a risk of bleeding. And that risk is obviously mitigated by your INR and platelet count. So that helps us to know if this patient is high risk for bleeding or not. Clinical status, is this patient the patient that's walkie-talkie on the floor, or is this patient that's in the ICU? That also kind of dictates, how we do the procedure. Any prior relevant imaging. So, if you're asking for us to drain an abscess in the abdomen, it'll be helpful to have a CT or ultrasound showing the abscess. And then any other procedures planned for today. So if your patient's going down for colonoscopy, if they have to do dialysis within a certain hour, it's good to know in terms of planning. And this is from the SIR consensus guidelines. This just shows that types of procedures in terms of low risk bleeding procedures, medium risk, and then high risk. And then this is going to be the recommendations in terms of lab tests that you want to get. So for low risk procedures, you could see that you want PT and INR, but usually you don't really need a platelet count. Whereas for the medium and high risk procedures, you would want to get that. And then this is going to be institution dependent, but based on INR and platelet thresholds for each type of procedures. And then this is another article that just kind of shows for each type of anticoagulation, usually what people want in terms of like when the last dose would be. And then this is when you can resume the anticoagulation. Again, this is just a general guideline. Your institution and your even individual IR attendings are going to have different preferences. And this is kind of a schematic just showing the daily workflow for an IR section. So typically they'll have a number of rooms where procedures are done. And then these boxes that are in blue are going to be scheduled outpatient procedures. And if you think about it, for these outpatients, they travel from a distance away and they're here, and then they wait in the PACU, and then they do the procedure, and then they go back to the PACU for recovery. So these patients, it's very difficult to have them reschedule, given that they're already there. So most of the time, the inpatient procedures, especially the non-emergent procedures, are going to have to be scheduled around the outpatient procedures. So for example, in room 3 here, in the morning, there's no scheduled procedures. So if you have any emergent or inpatient requests, those are going to be done here. And finally, this is just transition to talk about radiology rotations. So at 9:30 a.m., you get a page. It's your first admission. It's an outside hospital transfer for a second opinion on a subspecialty procedure after an extended and complicated course at the outside hospital. Maybe you'll think about doing radiology elective for your next elective. So for this part, I kind of broke it down into 3 types of situations. So the first one is that if you're doing a different specialty other than radiology, so if you're going into medicine or surgery, and this is kind of the rotation where you just want to learn a little bit more about radiology, I think what's helpful is kind of learning about the workflow of radiology and then also targeted exam for your specialty. Learning to recognize critical findings, kind of like what we talked about earlier in the lecture. And then also we know most people do radiology rotations during fourth year. You've gone through a gruesome, stressful third year. It's nice to just have some time off, especially if you're working on URAS during the beginning of fourth year. Most of the rotations for medical students, I usually just tell them to leave after a few hours. You can take advantage of this time and work on other things in life. And these are some resources that we found were very helpful. So Radiology Assistant is a website that they have a lot of images, which I think is very helpful. Most of them are labeled like this, and then they'll kind of go through each labeling like this with you, which is really great for learning imaging. Learning Radiology is also another great website. They have different topics, and then they kind of just have short lectures, kind of PowerPoint lectures you can go through to learn. And then these two, I think it's very good. These are what we call like, there's like passive learning and active learning. So these resources are really great for active learning. So Felson's Principle of Radiology is essentially this book that talks about reading chest x-rays and CTs, but in parts there's these short answer, fill in the blank questions you can ask yourself, and there's answers. So this kind of just reinforces your learning as you're reading the book. And then similarly, this website, xraycomics.com, this also goes through these short multiple choice questions and to help you kind of integrate what you're seeing on the images here. Next is for IR rotation. So I haven't done an IR rotation as a student, but we do rotate on IR as residents. I think so for IR, it's different than diagnostic radiology rotation, where for IR, you are able to manage patients, have responsibilities, and then kind of show your characteristics during the rotation. So most people talk about the 3 A's for doing well. So these are going to be availability. So showing up early and staying late. Affability, being able to get along with people during the rotation. So definitely know the techs well, know the nurses well, introduce yourself. And then ability. So this is the part where you have to know every procedure you do, you should know what the patient's history is and why you're doing the procedure. You should know the relevant anatomy for the cases you're doing. For example, if you're doing an endovascular case and you're getting access in the common femoral vein, you have to think about which vessels you're going through and then kind of knowing what the names of the vessels are. This is very useful. Any patient you do a procedure on, they're going to stay either in short-term recovery and go home, or they're an inpatient. They're going to go back to their team. But it's nice to check up on the patients just to see how they're doing. And then if there's any kind of complications, you'll be the first one to kind of identify those. Also, IR gets a lot of consults during the day. So each consult, you review the images and you also see the patient. So it's nice to try to help with the consults. And then the other thing is that knowing the steps of the simple procedures. Obviously they're not expecting you to know like complex like thrombectomy or like even tips when you're starting as a medical student. But just knowing like simple procedures and knowing what's the next step to do, I think is very helpful. And then I think it's always, you can know the student is very prepared when they're assisting you and they know exactly what your next step is going to be. So for example, if someone you're assisting is doing a central lining access, and then they've gotten access, and then you hand them the microwire to put the wire into the blood vessel, they know exactly that the next step is going to be this. And also, as a student, a lot of times you'll be managing the back table during procedures, and that's also very helpful for the team. So for the back table, for those who haven't done IR rotation, this is what the back table kind of looks like. So you have your sterile blue here, and then things frequently used for IR are going to be syringes for contrast. So these are things that are going to be injected to opacify the vessels. And as a student's job, it's very useful to keep the syringes replenished. So once they inject the contrast, they'll hand it back to you on the back table. And then you typically have one bucket with saline and one bucket with contrast. And then depending on each attending's preference, they may like it 50-50 mix. Some may like it 20% saline, 80% contrast. anywhere in that spectrum. So just knowing that to replenish this as you go, and then also to mix it with a proper ratio. And then also they'll be handing you lots of wires. After they use the wires and catheters, they'll be heading it back to that table. It's good to keep those organized. So for example, if you have any hydrophilic wires, you should have a bucket that's filled with saline. So put the wires within the bucket there. And then finally, also making sure, so usually there's a container here where you put all the sharps in to make sure that's organized. You don't want any loose sharps on the table where people can injure themselves. So always make sure that's placed in a nice place and all the sharps are placed in there. And then finally, for diagnostic radiology, this is for advice for people who are applying for radiology and you're doing a rotation. Either you're really interested in that program, and you're doing either an away rotation, or you're doing a rotation where you want to get a letter of recommendation from that rotation for your ERAS application. So one thing is you always want to look engaged, right? So you always want to be looking at the screen or talking to them. You don't want people to turn around and then see you on your phone. That just kind of sends a message you're not really interested. You may be interested, but it just seems like you're not interested. And we understand that during this time, it's a very busy time. You know, people get emails for interviews and things like that. And most people are very understanding. If you just say, hey, sorry, I have to schedule this interview right now. Is that okay? Most people would be like, yeah, sure, go ahead. And like, no problem. But, you know, if you have to use your phone for any situation, just let people know what you're doing. This thing, I think it's a typical pitfall for people. I think medical students come in, they think, oh, this is going to be like a regular clinical rotation where I want to show my knowledge, and then this is how the rotation, the people are going to think I'm a good medical student, and this is going to help me match. But I think a lot of the part is that there's really no expectations for medical students on these type of rotations. You know, even for incoming R1s, people don't really expect you to know much about radiology and anatomy in general. I think what's more helpful is getting to know the residents attendings on a personal level. Just kind of like, you know, asking about images to show your interest, but also talking to them about like what their hobbies and interests are, talking a little bit more about yourself too, so they get to know you better. You know, we get a lot of medical students rotating. And then at the end of the day, it's always nice when you're looking at someone's ERAS application and you can put a face to a name. And, you know, it's very hard when you have a ton of names and they all have similar scores, but you don't really know anything about them. They're just basically a name on a page for you versus someone that you rotated with and you know a little bit about. You're like, oh yeah, this is so and so. That they were very nice to work with. And this is, I think, helpful. The other thing you can do is that, you know, a lot of times these rotations are very laid back. You don't have a lot of things to do to showcase your abilities. But if you wanted to start a small research project, doesn't have to be anything big, but if you just, in the beginning of the rotation, you can approach an attending or resident and say, hey, I'm really interested in doing some research during my rotation here. And then usually, you know, this is essentially free labor for them. So most people will take you up on this offer. And I think it's good to just look at like upcoming conferences for abstract submissions. This kind of puts a deadline for both you and the attending or resident you're working with to get something done. So at least by the end, you have something tangible to show for it. So one conference I found is ARRS. Usually their deadline is in late August and early September. So this is like right before ERAS deadline. So at this point, if if you're working for a abstract for this conference, you know at least you'll have something submitted that you can list on your ERAS application by then. And then finally, if you're really interested in the program, if you have any ties, like, you know, if you're from that area, or if your family lives in that area, or if your spouse is doing something in that area, definitely to make sure to emphasize those ties during your rotation. I think, you know, looking at prospective residents and applicants, programs, they want people who want to come there. So people that have any ties, I think, are going to be reasons for them to come to the area and also to stay in the area after residency or fellowship. And programs are always, you know, looking to recruit future attendings as well. And then the best way to do that is to recruit residents who want to stay, and then eventually sign on as attendings. So if having ties, it's always good to emphasize those during your rotation. Finally, always remember that this is kind of a two-way street. You're also looking at the program too. So, you know, when the residents staffing out the attendings, kind of gauge how that interaction is. You know, is it something that you want? You know, is there something that's very relaxed and comfortable? or is it something that's a little bit more uptight? And then kind of put yourself in the resident's shoes. Like, would I want to be a resident of this program? Is this something that I would want to do on a day-to-day basis? And kind of really evaluate the program from your perspective as well. Okay, so that's all the slides I have.